Thank you. So always a challenge at this conference to decide where to target a talk because we have a very diverse audience from, I gather, around the world this year, which is wonderful. And I know that in the audience, we have a mix of people who may be living with pain and headache by definition. There's a good proportion of you that have headache. And of course, we've got family doctors, neurologists, headache specialists, pain specialists, psychologists, allied health providers. So knowing exactly where to target the level of this talk about headaches is always a challenge. So I hope that I will get the right mix for people. It's a little bit light on the basic science and pretty heavy on the clinical. So hopefully that will keep people's interest and attention, and hopefully people can take away some practical pearls for themselves or their patients. I do not have any financial disclosures to make. Three main objectives. I was going to just begin by just quickly reviewing the diagnostic criteria for migraine. We've heard some really wonderful talks about migraine therapeutics, but I thought before we talk about headaches that are not migraine, we should make sure we're all clear on what is migraine, particularly since it's the most common primary headache that we see clinically. Tension type headache is arguably more common, but we don't tend to see it in tertiary headache centers to the same extent. I'll talk about just a sampling of non-migraine primary headaches. These are less common by and large, but interesting. And some of them I think can be really important to recognize in your practice because although they're rare, they can be quite devastating, either because of their sequelae or because of how difficult they are for patients to manage. And their treatments are different than migraine and tension type headache. And then finally, a few examples of some worrisome headaches and just a review of when to worry about headaches. So first of all, just a brief mention of how I think about headaches, and I think how probably most doctors think about headaches when somebody comes to the clinic with concerns about a headache. Because migraine is the most common reason for a patient to come see a doctor about headache, most of us think about the features of migraine headaches first and foremost. We call migraine a primary headache, meaning that it's not because of some other things such as an injury to the head or a tumor, for example. And there's many different primary headaches. Migraine is the most common one, but there are many others. And so one way of kind of lumping them in your mind and thinking about a patient who has headache is to think, is it a short headache or a longer headache? Migraines tend to be longer than 4 hours. There's a variety of other headache types that are shorter. And of course, that is dependent a little bit on whether or not someone treats their headache as well, because of course the pain will be shortened if you have an effective treatment. And if it doesn't look clearly like a primary headache, or even if it does, we always do a quick search for any red flags. So these are features that make us think, ooh, there might be something else going on here. If red flags are present, that's usually a reason to be a bit concerned about the headache. And often it means that we need to do some imaging or other kinds of testing. If there's no red flags present, that doesn't necessarily mean we're dealing with a primary headache. It may be that we're dealing with a non-worrisome secondary headache. So for example, perhaps it's a chronic headache that has come after a concussion. So not worrying for something like a brain tumor, for example, but no less disabling for the patient. Caffeine withdrawal would be another example of a not so worrying, but still secondary headache. So those are sort of the big categories that we lump headaches into. And there's lumpers and splitters in the world, and neurologists more often than not are splitters. And we use the International Classification of Headache Disorders, which you can download from the internet, to help refine the diagnostic criteria for headaches. And this is useful clinically, but also, of course, for clinical trials. And so the criteria can be quite important. So I'll just briefly touch on the primary headaches. There are many. Number 4 is a big grab bag that I'll touch on a little bit later. And migraine is the one we see most commonly in practice. Tension type headache, if you went and surveyed on the street, might be a bit more common. And then there's a group of unusual headaches called the trigeminal autonomic cephalalgias, which I'll come back to. In terms of secondary headaches, again, a great big grab bag that can range from psychiatric disorders to trauma to structural problems in the head, infections or substances. And substances could be using too much codeine, it could be using too much caffeine or withdrawing from caffeine, etc. So there's a large range of what we call secondary headaches. So just coming back to what does a migraine look like, in case there's anyone learning this for their exams or certifying licensure examinations. There's a nice mnemonic that some of our residents came up with here in Calgary, 543210, to help you remember the diagnostic criteria for migraine. This is how it's written in our official diagnostic criteria. So I highlighted the 5, 4, 3, 2, 1, and 0 for you. So we don't usually diagnose a migraine on the first presentation of somebody having a severe headache. We look at the duration of attack, so 4 hours to 3 days, if it's not treated, that is. A headache has certain pain features if it's migraine, and we need 2 of them, not 4. That's important because it means that migraine patients can present in a variety of ways. Sometimes they'll be prostrate, vomiting, completely disabled. Other times they might be just a little tired and able to give a talk at a big conference and still have a migraine at that moment. So the pain characteristics are the location, so unilateral more often than bilateral, pulsating, moderate or severe intensity. So these tend to be a bit more of a disabling headache. And the pain is often aggravated by routine activity. So I often ask people, if you had to climb a flight of stairs, would that hurt your head when you have one of these headaches? And then during the headache, there's 2 associated features, and you need to have one of those to meet the criteria. So nausea and or vomiting, or both a sensitivity to light and sound. And then this important E criteria is present for all the headaches we diagnose. You want to make sure it's not accounted for by something else. So ruling out other causes, meaning this type of headache is a diagnosis of exclusion. We don't have a diagnostic test or a blood test or an imaging test that confirms that something's migraine. We have these criteria and ruling out other things where appropriate. So that's the migraine criteria. The reason I'm mentioning these is because migraine overall is very underdiagnosed in the general population. A lot of people say, well, it's just a headache. But when they talk to somebody who knows the criteria, it turns out, sure enough, oh, those headaches are present when there's a weather change and when there's a menstrual cycle. And in fact, they're throbbing and you're a little sensitive to light and sound. Turns out you have migraine. Then people can get onto effective treatments. And likewise, people are often undiagnosed because they have the belief that it's not a migraine if they don't have an aura, because they know someone else who might have an aura. So auras are these transient neurological symptoms that often precede the headache, and they can be a variety of things. Visual is certainly most common, but they can be sensory. People can have difficulties with speech or language. They can be motor symptoms such as weakness. Rarely, migraine auras can consist of symptoms that come from a brainstem type distribution, or even vision change in one eye, which we call retinal aura. Those are really rare. Key things about auras is they come on gradually. They typically last less than an hour. Often there's more than one symptom, and they tend to kind of march along in a progression that makes anatomic sense for how things are kind of laid out in the cortex of the brain. Why I mention it also with the underdiagnosis and the idea that people have to have an aura in order to be diagnosed with, certainly don't, because really only about 20 to 30% of people with migraine will have auras. So it's certainly not an essential feature to have a migraine diagnosis. So like I said, we have a very variable presentation. People can be really sick with migraine, or people can be just bothered by it. A few key points: the aura doesn't have to be there. If you're seeing an aura that's one of the more unusual ones, I always want to caution people that it needs to be investigated carefully. Remember, migraine's a diagnosis of exclusion. And so if you're seeing motor symptoms, brainstem symptoms, vision symptoms in just one eye, pause before throwing down a diagnosis of migraine aura. One of my teachers, who taught, I'm sure, a number of other people that are at the table here, was Dr. Alan Purdy from Dalhousie. And I can remember he used to say, if you're thinking of diagnosing a basilar migraine, that's now called migraine with brainstem aura, don't. It's a really rare type of aura, and it can be mimicked by a lot of other things that are more sinister. And so you really need to image and make sure people don't have something like a stroke, a basilar clot, neoplasm, MS, etc., if you're thinking about entertaining a brainstem aura diagnosis. So I mentioned I'm going to give a tour, really just a brief sampling of some non-migraine primary headaches. This is a list of primary headaches. There's lots of them. I always like to point out that neurologists can be a little bit fun. This is cold stimulus headache here, but halfway down the list, that's an ice cream headache that people talk about. So it's actually in our formal headache classification criteria. As you can see, there's a lot of different ones, several that are pretty uncommon, but important. And some that are probably under discussed, but probably are out there more than we know, such as headaches with sexual activity. and a few that can be quite serious and need to be looked at very carefully. So thunderclap headaches need to be investigated. New daily persistent headache usually needs to be investigated. And I'm not going to talk more about those, but if people have questions, certainly they can. I'm going to touch on a few of the others though. So we'll talk about a couple of different non-migraine primary headaches. And I'll start with a case. This is Mr. P. This is a 52-year-old man who's had quite severe headaches for 20 years, and he's been to the emergency department many times. And eventually one of the emergency doctors said to him, actually, this is not migraine. He had been told it was. And the emergency doctor recognized it because he happened to have the same diagnosis. And many other docs had not recognized this because it's not a very common diagnosis. So he was referred to see us at the headache clinic because of this doc who happened to have the same thing. So when you ask a really detailed history, you get the story of headaches that turn up every fall. He would get them every day. They could last between 45 minutes and an hour and a half. He describes them as horrendous, like someone's trying to gouge his eye out with a spoon. They're always on the right side, right in behind his eye. And each year when it's coming back, he describes what he calls a shadow, a sort of feeling that he starts to get in the temple and in behind the eye that tells him this headache is on the way. Once they start, they come on 4 times a day, and he would always wake up with one at 2 in the morning. So this is quite a classical description of this diagnosis, and hopefully a number of you who are listening will already know what this is, but a few other features. He'd been told he had migraine in the past because he had these one-sided headaches, and he would say, yes, I am sensitive to light. But in fact, when you ask him more questions, he was only sensitive to light in the one eye, and that's actually not typical of migraine, but is typical of this entity. During an attack, if you asked him, he would say that yes, indeed, his eye runs. And a question that I hope people will remember for use in their clinical practice is, what do you do when you get an attack of this headache? So the typical response from a migraine patient is, I lie down in a quiet, dark place and I try not to move. A person with this diagnosis, if you ask them whether they do this, they lie down in a quiet, dark room, they inevitably say, heck no, this pain is way too much for that. They pace and rock and cry out. And if you Google this diagnosis, you can see YouTube videos of people suffering with these, and it's really very dramatic. And the other little clinical tip is that this patient reports even just a sip from a beer or a drink of any kind of alcohol would reliably trigger one of these headaches once they would begin each fall. So the diagnosis that we're talking about is cluster headache, and I don't want people to think that this is a common headache disorder. It's not. However, the diagnosis is commonly missed, and it's reasonably treatable because the pain is truly an extraordinarily intense pain. Sometimes this is called a suicide headache. It's important to make this diagnosis because we manage it differently than we do other primary headaches, and if you can make the diagnosis and get the patient on appropriate treatments, it can be life-changing for them. So similar to the migraine criteria, we don't diagnose this after a single attack. It's an extraordinarily bad pain. Patients, when they describe this, really can't be dramatic enough in the terms that they use to describe it because it's really something. It's a short-lasting headache. So this headache typically is less than 3 hours, usually more than 15 minutes. The important features are that it is it's one-sided, almost always behind the eye, but it's associated with some unusual features. So autonomic features can be present. So you can have a red eye, runny nose, sometimes some swelling or drooping of the eyelid, or even a change in the one side of the forehead or facial sweating, changes in the pupil. And then if those symptoms aren't present, sometimes people discard this diagnosis as a possibility. However, as an alternative to that, you may just get agitation and restlessness. So that's where that question about what do you do when you get a headache becomes very important. Now, these headaches are short, and as a result, they can also be frequent. And so people can have 1 or 2 a day to 8 a day. So when the headaches are active. And of course, like all the other headache diagnoses, we want to make sure this isn't something else. So diagnosis of exclusion. So make sure you're thinking about other alternatives. So it's a short-lasting headache on one side with some associated autonomic features or agitation. Interestingly, it's a little bit more common in men. It's not very common, so you might see one in your career if you're not a headache specialist or a neurologist. You might see none. If you're a neurologist or a headache specialist, you probably see them more frequently. We don't fully understand the science of this headache, and I mean, arguably, we don't fully understand the science of migraine either, although I think we understand it a bit better than cluster. There is some evidence that there's a genetic component to cluster headache. There seem to be higher rates within families and within twins, but we don't have a clear genetic link. There's some suggestions of associations, however, and one is with orexin and this hypocretin receptor 2. And so there is a polymorphism that when it's present, the likelihood of having a cluster is about twofold. However, that's really very preliminary data. In terms of the physiology and what we know about that in cluster headache, we know that there's activation of the trigeminal vascular system, and Dr. Becker showed a nice picture of parts of that during his talk. So we see the trigeminal complex being activated and changes in the blood vessels. But along with that, we also see activation of the parasympathetic fibers. It used to be thought that the parasympathetic fibers being activated might activate the trigeminal vascular system, but it seems more likely that trigeminal activation triggers the parasympathetic activation, and that's what leads to the red runny eye and so on. Importantly, it seems like there may actually be a generator for cluster headache, probably in the posterior hypothalamus. So we have some studies using PET scanning and functional MRI that point towards that. And then the agitation is an interesting piece because agitation is not something that we think of as coming from one peripheral nerve or from the brainstem or the spinal cord. It is something we think of as coming from the frontal lobes and temporal lobes. And so there is some literature that tells us there may be activation of a frontal circuit called the salience network. And that's a whole bunch of linked structures in the higher parts of the brain that are involved in helping us to pay attention to what's important around us and respond to things that might be scary or frightening or need avoiding. So it's an interesting piece and may account for why we see this very characteristic agitation with cluster. It's more than just a response to the pain, seemingly. Treatment-wise, it's quite a different approach than managing migraine. So to deal with an individual cluster attack, we do use triptans, but we want to be really smart about that and choose the ones that act quickly, because an oral tablet will take longer to work, and this headache is short-lasting and so intense. A fast action becomes very important. So we'll often use sumatriptan subcutaneous injectable, or else one of the 2 triptans that's available is a nasal spray. Interestingly, and I'm not sure that we have a very good understanding of why, high flow oxygen, just from a tank through a mask, put on at the beginning of a cluster attack often will settle it down very effectively as well. We do have prophylactics that can keep the number of attacks down. And again, unusual treatments that we don't always use in migraine, so why it's important to make the cluster diagnosis when it's present. And these are things like verapamil, which is a calcium channel blocker, most often used in heart disease. We use it at higher doses for cluster. Lithium and topiramate. Topiramate is often used as a migraine preventative, but may be of some benefit, certainly not first line in cluster. And then if somebody's having a very bad go, they have 5 or 8 headache attacks a day, they're really intense, they aren't getting aborted very quickly or easily with the preventatives and the triptans or oxygen, often we'll give a course of steroids, either through occipital nerve blocks on the affected side with a local depot steroid, or else oral prednisone. Obviously, there's lots of side effects with steroids, so we have to be mindful when we're making the decision to start someone on those. So that's our first non-migraine primary headache. The next one I will tell you about, I actually got on the phone with Dr. Dodick, who many of you just heard from, just as I figured out what was wrong with him and had to politely say to Dr. Dodick, thanks for taking my call, but I think we've got it now. This is a gentleman that I saw, I think when I was actually doing my fellowship with Dr. Becker, a 58-year-old gentleman who had short-lasting headaches. He described them as excruciating. They were interfering with all of his activities of living, including his work. The headaches would come on and last about 20 seconds, and he described this intense squeezing pain that would come on sort of in the temple or the back of the head and then radiate forward in behind his eye in what he called a sharp wave. And with that, he would get some redness of the eye and some tearing, and it had been getting worse. He had seen a number of neurologists and then wound up in the headache clinic and over the course of a few years. And I followed him for about a year with this diagnosis, and it was getting worse over time. And at one point, he told me that he'd quit his job and booked a trip with his family because he didn't know that he was going to be able to ever do something like that again because it was just getting worse and worse. And he actually was concerned he was going to pass away from this problem that we were following him for. So the description, the clinical description of this man's headache fit very well with one exception, with this short-lasting unilateral neuralgiform headache attack. So that's a mouthful. Basically, these sound a little bit like cluster in terms of their intensity. They're fixed on one side. There's some autonomic features and changes often with the eye. They're quite intense, but being so short, you can have a lot more of them in a day, and they can last between sort of a second and several minutes. Typically, they'll have injection of the eye, so redness of the eye, and some tearing. And then there's some variants where you can have some other autonomic features similar to what you can get in cluster. And again, you're always wanting to rule out other causes. So we gave this gentleman a diagnosis of 𝐒𝐂𝐂𝐑𝐈𝐁𝐄, which stands for this mouthful of words here. This is a difficult headache. It's uncommon enough that we don't have big clinical trials to tell us what works. And in addition, we don't have a clear protocol for what to try. So there's a lot of case series, and these are things we often try. So lamotrigine, topiramate, and gabapentin were all designed as anti-seizure medications. Lamotrigine probably has the best results for a primary 𝐒𝐂𝐑𝐈𝐁. There is some evidence for IV infusions of lidocaine. Those are challenging to achieve. To find a place where you can get an IV lidocaine infusion is quite difficult. Certainly here in Calgary, it's an undertaking to find that. But another key point is that there seems to be an association in some of these cases with posterior fossa lesions or pituitary lesions. And so that's my segue to the next and final part of the talk, which is recognizing headaches that are worrisome. And I'm going to circle back to Mr. L as a starting point. So I mentioned briefly that this gentleman was getting worse over time. And of course, in the beginning, he was imaged, and we imaged him repeatedly over time because of the fact he was progressing, which is a red flag. And his imaging was interesting because he has this big cyst. I don't know if you can see my cursor, but he's got an arachnoid cyst in the posterior fossa. And because he was progressing, he kept coming back and saying, I know my cyst must be getting bigger. Can you check again? And so everyone kept checking again, and the reports that would come back from our colleagues in radiology would always say he has a big arachnoid cyst, it's stable, this is an unlikely cause of headache, because these actually usually don't cause headache at all and certainly aren't known to cause this kind of headache. So after trying everything and multiple MRIs that looked like this, I actually sent a note to our colleague, Dr. Dodick at the Mayo, to say, hey, can I send this patient to you and could we touch base about it? And as I was waiting for him to call me back, I quickly pulled up the images again and laid eyes on him myself. And because I thought it's embarrassing when we call the super expert and we've missed something. And sure enough, I pulled the images up, and on the coronal views, so cutting this way, we could see this lesion. So that's the pituitary gland, and this is actually a pituitary adenoma. And I had actually just pulled the image up in front of me when Dr. Dodick called me up, and I shamefacedly said, I don't actually think I need to talk to you anymore, but thank you for calling me back. I'm sending my patient to a surgeon. So with 𝐒𝐂𝐑𝐈𝐁, the message I'd want you to take away if you have a patient with one of these short-lasting headaches is certainly do imaging, and dedicated imaging of the sella, which is where the pituitary gland lives, is very valuable, because if you find one of these adenomas, there's actually quite a large number of cases now in the literature that say if you can take these out or treat them, sometimes pharmacologically, the 𝐒𝐂𝐑𝐈𝐁 will disappear. And sure enough, he went for a resection. He's found to have a growth hormone releasing tumor. And when that was gone, his headache was gone, and we actually haven't heard from him since, so he's done very well. So when do we worry about headaches? When are there red flags, and when should we image? Dr. Dodick wrote the book on this, quite literally. This is from one of his papers. We use the acronym SNOOP when we're teaching this to students in medical school. So when any of these are present, that's when we should be thinking about imaging. And of course, I'm sure all of us can think of other examples as well. But if someone has systemic disease, such as cancer, anything that affects the immune system, connective tissue disorders, diseases like HIV, you would have a very low threshold for further imaging. Likewise, if there are any neurological symptoms or signs, an onset that is thunderclap, so worst intensity ever imaginable within an instant, absolutely. And that actually is an indication for emergent imaging, because it can be a reflection of something like a ruptured aneurysm. Onset after age 50 is usually an indication for imaging. There's more pathologies that can come out after 50, and most of the primary headaches, certainly migraine, which is the most common one, appears more often than not before then. If the examination shows any signs of raised intracranial pressure, such as papilledema, headaches that are worse when someone stands up, suggesting that their intracranial pressure is low, or headaches that are worse when the patient is supine or lying down, which suggests the intracranial pressure may be high. If you bear down and bring on a headache, that can suggest that there's raised intracranial pressure or sometimes some anatomic abnormalities that can cause this. And then any headache that is progressive, as in the case of Mr. L that I just told you about. So that's Snoop. So I'll tell you about another case. Ms. S. This is a lady who I might not have imaged, and somebody else had already ordered an image by the time I saw her. A 24-year-old lady who had occasional moderate throbbing headaches during her periods. But she'd been back and forth to the Emerge a few times and referred to me in an urgent clinic because of a refractory migraine, which had been present for 2 weeks, according to the referring doc, who had also ordered an urgent MRI. She reported nausea and vomiting. Her headache was severe. It was throbbing. It was on the right side. She was sensitive to light and sound. And she was having difficulty sleeping because of the pain. And she was finding that she was a little better if she slept a little bit propped up. And this was a young, healthy woman with no other comorbidities. And when I saw her, she looked very well. And she had a normal neurological examination, including the eye exam. However, it so happened her MRI was booked later that day. And so I had her just come back at the end of the day so we could look at it together. So if you look at that history, there is one red flag, and it's this. She did indeed have a positional headache. Her headache was worse when she laid down. In the context of this otherwise well-looking woman who had a history of migraine, I have to admit I did not think it was very likely we were going to find anything on imaging, and I think had the Emerge doc not already ordered an MR, I don't know that I would have. I might have just followed her. But I'm glad that he did, and I'm glad that I saw her again at the end of the day. So this is a picture of what the draining veins from the head look like. This is normal. And this is a picture of our patient. What you see here is a clot in her sigmoid sinus, and a sizable one at that. And so the important other key that I didn't share with you, which is kind of sneaky of me, is this patient was on oral contraceptives, which can be a risk factor for dural sinus thrombosis or cerebrovenous sinus thrombosis. So the message here is, even though the patient looked quite well, there was a red flag, and ignoring it would have led to a miss. And so really paying attention to the red flags is quite crucial. Dural sinus thrombosis can be a benign phenomenon. Some patients do fine. They recanalize by themselves, and sometimes even the diagnosis is made incidentally. Other times, though, these clots can extend and cause a lot of increased pressure in the head. They can lead to infarctions and even death. So it can be a very sinister diagnosis as well, and often needs treatment with anticoagulants and sometimes even mechanical removal of clot, which sometimes we do here. So our next case is Miss C, a 32-year-old woman with 2 months of a moderate headache over her whole head. She says the headache is worse with coughing, bearing down, worse in the morning. Sometimes she has episodes of transient darkening of her vision, and you would have to ask about this. Lots of patients might have this and not volunteer it. This lasts a few seconds, and she also, when you ask her, will tell you that she's got some noise in her ears, which she described as a mechanical sound or a rumbling, and she would notice that the most when she was in her bed at nighttime when things were quiet. So if we think about whether there's any red flags in this case, hopefully all of you can appreciate that there's quite a number of them. She has visual symptoms. Her neurologic examination might have been normal, might not have been normal. I will tell you that it was abnormal. She had papilledema, which is swelling of the optic disc at the back of the eye. She has a headache that's worse when she's laying down. It's worse in the morning. She can bring it on by Valsalva. And it's a new headache as well. She doesn't have a history of migraine. So lots of red flags there. And so certainly imaging is warranted, because you might be thinking about the possibility the patient has raised intracranial pressure. If that's so, then we need to be thinking about what could be in the head causing that. Is there a clot? Is there a tumor? Is there a bleed? And so this is not the patient's imaging, but representative imaging. And there is no tumor and no clot in this image, but what there are some subtle changes that point towards a diagnosis of something called idiopathic intracranial hypertension. Again, not a common diagnosis, but it's an important one, because if it's not treated, it can sometimes lead to vision loss, because the increased pressure can cause changes to the eye and the optic nerve, resulting in permanent visual alterations and loss. So there's subtle findings on MRIs in some of these patients, but they really have to be interpreted in the context of the patient's history and exam, because sometimes you can see some of these findings and the patient doesn't have this. So things we look for are flattening at the back of the eye, a tortuous course of the optic nerve, increased spaces where there's spinal fluid around the nerve. And then sometimes we can see an empty sella. So this is where the pituitary lives, and it can look like a bit of an empty space in patients who have this. In this case, that's from one of our radiology journals, after treatment, you could see that the globe is more rounded, there's less space around the optic nerve, and it's not as twisty as it is in the image B, and also that the pituitary seems to have sort of reconstituted in the sella. So this is an important diagnosis because if not treated, can lead to vision loss. It can result from a variety of different systemic conditions, so endocrine problems, a whole bunch of different medications. I've listed a couple of common ones there, but there are many others, so it's worth looking up if you're wondering about this diagnosis. And we can see it in people with a high basal metabolic index or who've gained weight. Sometimes we can see stenosis of the veins, and there's a host of other conditions as well. Importantly, these patients need to see an ophthalmologist or a neuro-ophthalmologist to track their vision. We treat the underlying or causative agents or conditions, and often we'll use agents that are going to decrease CSF production to reduce the pressure in the head. Sometimes we use serial lumbar punctures, and in people who are quite refractory, we'll occasionally have to do a shunt and even a fenestration of the optic nerve to depressurize the optic nerve to preserve vision. Now I can tell you the very same story, and the presentation could equally be this. So again, just a reminder that if these red flags are present, these are the diagnoses we have to think about, and imaging is usually warranted. I'm probably coming close to 30 minutes, so I'm going to sum up there. This is a very quick tour over a handful of things, but there's a few key messages to take away. So first, always asking about the symptoms of the primary headaches and thinking about the big buckets into which we put those sort of longer headaches and shorter headaches, but always checking to ask, what do you do when this headache occurs? Because that can help point you in the right direction. Asking about the tempo, autonomic features, and agitation can help you to not miss things like cluster headache, but also can start to twig you to the fact there may be red flags present. And if so, think about Snoop. Never ignore red flags. Red flags warrant further investigation. You'll be glad you did it. Sometimes things will be just normal, and some people do have some red flags that turn out to be nothing, but you must pay attention to them. If the headache's atypical, be sure to image and look for any secondary or systemic causes. Thanks for the opportunity to speak with you. I hope a few people will take away some pearls from that, and I will turn over to Dr. Becker, who will introduce our next speaker.